Thank you. Omar, I think the Nobel syndrome particularly raises its ugly head when it comes to emergency cases. You hardly hear of it very much when it comes to referrals or outpatient. Most of the tragic incidents we've had in hospitals where patients lose their life because of there's no bed is when they are brought to the emergency and the emergency has no space. That is where the problem is. It appears to show that our management of our emergency departments are not properly conducted. One, any patient per protocols, any patient who gets to the emergency department must be triaged, identified, and given a color code depending on the severity. He sees a doctor immediately. He can wait for 30 minutes. He can wait for 1 hour, or he can be referred to the OPD, outpatient department, to be attended to.
This determination is done as soon as the patient arrives?
Patient arrives.
Who does this?
It is the triaging nurse. Okay. Then from there, a doctor is called where the need be. I'll come to the colors I've explained to you. Okay. So let me continue. And then no one should stay at the emergency department too after 24 hours. Okay. After 24 hours, you are either moved to the ward, you are moved to the intensive care, or you are going back home. If there is no space in the hospital to take them out of the emergency department, there should be a coordination between all close by hospitals to see whether they have a space for that particular patient and they have the capacity to treat that patient.
A patient must not be in the emergency ward for more than 24 hours.
4 hours. The reason is that that is a transit point for you to be stabilized and then move to the next level. You may be moving straight to theater, after that to ward. You may be moving straight to a ward, or you may be moving to another hospital. But you can't stay there for more than 24 hours. It is simply because we don't manage these cases very well at the emergency. Sometimes they'll say there's no space at the ICU, there's no space in the ward, and then the rest. That is where we have this. But let me tell you, there's a guiding principle. There are guidelines governing emergency department. Coming back to the case that we are talking about, and I don't like to speak on my own. I would like just to read some few lines from the guidelines. The guidelines is from the Ministry of Health, Emergency Accident and Emergency Services, 2011. And that is the Ministry of Health, Accident and Emergency Service Policy and Guidelines. It says, and I'll read, Triage team should assess all patients presenting at accident and emergency department. Triage teams. And triage teams are either made up of nurses or doctors, depending on the level of the hospital. They didn't say a patient who is referred. Anybody who presents, whether he has a small toothache, he has a small headache, he has a big wound, he is gasping for breath, he is in shock, the person must be triaged. That is what it says. So no one has the right at the emergency to turn out a patient and say, go to the next hospital.
Yeah, but the point is that if you accept the person has to go through the system and you know that at the end there's a clog, so what's the point of accepting?
It doesn't matter whether there will be a clog or not. That is where we have the problem. They said they must be triaged. And the next step is, it is not me.
And this triage, is it done in the ambulance or you are brought to
You are brought down.
Okay.
The triage nurse doesn't go to the ambulance. Okay. You must be brought down to the nurse at the entrance of the emergency or the doctor, depending on the class of hospital. Then you are assessed to see your vitality. That is why they give you a red coat, a orange coat, a yellow coat, and then a green coat. A red coat means you can die in 5 minutes.
Okay.
A yellow coat means if you don't attend too quickly, in 30 minutes you can get complicated. That is an orange coat. And then a yellow code means that you can wait for maybe 1 hour, 3 hours. And then the green code means that you can even wait till 24 hours, or you can go and see any doctor at the normal OPD. Why did they do this? To make sure that anybody who gets there gets the quick attention, gets sorted out to determine his gravity. So to tell a relative of a patient that take him to the next hospital without going to see, I want to educate the public and then remind my colleague doctors and health professionals, this is unacceptable in the first place. No matter the circumstances, you are first of all having to try the patients. If you see that he can die in 5 minutes, The doctors have the right to abandon any patient they are treating as yellow and attend to a red. The doctors, they have the right to abandon somebody who can survive without treatment for 4 hours and treat somebody who will die in 5 minutes.
And they know this.
They know this. That is why I say I'm reminding. They are my colleagues. I'm reminding and I'm educating the public. So we all get this thing in our brains.
Does it mean then that if I come to a hospital, I must be admitted at that hospital even if they don't have the capacity to admit me based on their infrastructure needs?
What did I tell you from the beginning? A patient should not stay more than 24 hours at the emergency.
Yeah, but I'm looking at...
Meaning that even if there is no space, you must be triaged. One. And you must be... a doctor must be assigned to you if you are at danger to die. A doctor can also be assigned to you if you are at an orange, depending on the cases they have. You can decide to do forced transfer of those who are stable to the nearest hospital. That is why you have the 24 hours. Anybody at the emergency, they can either go to ward, theater, ICU, MOC, or be referred to another close hospital. Those who can move without repercussions on their disease, the transportation would not cause problem on them, can be moved. If you think that my emergency is full, but there is space in the ward, I can move somebody. That ambulance that brought this person, you might have coordinated with all other hospitals that are close by to move one person out of the hospital to take the one that cannot move out. Or as the minister said, you can decide to put people on chairs because they can sit on it, but others cannot. Because you can't play with the patients who is red, yellow. Orange you can play a little with. But yellow you can play a little bit with. Orange and red you cannot.
These things you say are the ideal situations. Have
you
thought of what happens at night, midnight, 1 a.m., 2 a.m.? By then, there are very skeletal staff around. A lot of the time, most of them are hiding in their rooms, sleeping.
This is where you come, and I don't agree to, that there are skeletal staff, there are this. That is the problem we all have created. This is the problem we all have created. And if we want our emergency department to work, and we have designed, we have drawn guidelines and policies on how to manage emergency cases. It's not me saying it, it's for the Ministry of Health.
Since 2011?
2011. And luckily, I was a member of the team that designed this. Okay. And I know it outright down. And I know what they're supposed to do. And they know. We educate, just that we have to follow up and remind them. Look, challenges at emergencies exist in every country, even the US, even in UK, even in Russia, China. There is problems at emergency. But you must prioritize using this guideline. If Mr. X came with asthma, has been nebulized, and he's feeling better, you can give him a chair to sit and put somebody there. You don't also put a patient at the emergency because of critical conditions and keep him there for more than 24 hours. Or else you'd cause the doctors there to get exhausted. That is why they have to move to where? To the ICU. That is where ICU, they have enough nurses waiting for them. But emergency nurses, they rotate and they move very fast. And they're supposed to be running around. They can't concentrate in treating somebody who is severely ill. They can only do what? Resuscitate. The work at the emergency is not to treat critical care. It's to resuscitate the critical care and move them to the critical care department or to the theater or wherever they can. So the doctors there who are doing critical care management and the nurses there will take care of. After emergency, they have to triage, know your condition, whether to give you the fullest attention in 1 minute or delay your treatment or refer you to another nearby hospital. And they are supposed to create the environment to ensure that a next patient coming, they can receive. It is only when we have mass casualty that will bring so many patients that is overwhelming the hospital that it may not be applicable. But still, they'll still go by the red, orange, yellow, and green. But in this case, red, if you are overwhelmed with disease, with so many emergency cases, red are overlooked at the scene of the emergency.
Okay.
But the yellows, the orange, and the greens are attended to.
In this particular case that has triggered this new conversation, someone knocked him down at Kwame Nkrumah Circle.
Yes.
Before an ambulance picks someone like that, I mean, so for the people who were there, they just simply call an ambulance.
Yes.
Or they put the person in a taxi and rush to the nearest hospital.
Yeah.
What should happen between that movement? If you were an ambulance, what should happen? Where does the ambulance head to? How do they know which hospital is available to take who? For the ordinary person who has just rushed this accident victim in a taxi, they want to just find the nearest hospital. What should they do? How is that coordination done? Who does that coordination? Because there appears there should be a database of someone knowing which hospital is ready at what time. Who knows that thing, and how do I find that?
Omar, every emergency department is ready 24/7.
So
every emergency department.
So a circle, if they move the person to the Anaba polyclinic, they should be ready.
They must be ready. That's what we call accident and emergency department. They are supposed to work 24/7. It is the management and administration that is creating the problem.
Even if it's a small clinic, they should have.
You are saying small clinic. You see, so I think in Accra, even if it's a small clinic, at least and they have a small corner there as emergency department or the emergency unit, they are supposed to assess to see whether he can make it or not.
Talk to us of a Rich Hospital, which is a big place.
Now you are speaking. If you go to Rich Hospital, Police Hospital, Legon, Bank Hospital, Kolebu, or any of these hospitals, we have Police Hospital, 37 Military Hospital, there is no way they should turn out any emergency patient.
Under no circumstance.
There's no way. There's no way.
Because in this case, this gentleman was moved from to Police Hospital, Ridge Hospital, and then eventually Kolebu Teaching Hospital, where he was pronounced dead.
Yeah.
This movement should not have happened.
They cannot. They are not supposed. They are supposed to receive the patient and follow the guidelines.
So if I find someone who is knocked down, I should put the person in the car or a taxi. If I don't get an ambulance, I should go to the nearest available place. Health center.
Health center. And I think generally in Accra, we know hospitals that attend to emergencies. Yeah. It should be general knowledge. Yeah. If you live in a community, you should know which is the emergency or the hospital I can go if I have an emergency. Okay. The ambulance team, they know all the emergency centers. They know all the good emergency places, not units, but departments. Hospitals that have emergency departments.
I'll come back and ask you about attitude because you headed the hospital, and that's the conversation I want us to look at. The attitude of the nurses, the attitude of the doctors. So if everything is okay, what happened?